I would like to welcome everyone here to the 2019 Annual Meeting of the American Academy of Neurology here in Philadelphia, which is the world's largest gathering of neurologists and neuroscience professionals. My name is Renee Tessman, and we are joined by members of the press here in Philadelphia, as well as those joining us by conference call. At this year's meeting, more than 3,000 scientific abstracts are being presented by researchers from around the world, here to share the latest scientific advances in brain disease. Today we welcome Dr. Natalia Rost. Dr. Rost is chief of the stroke division at Massachusetts General Hospital. She's also professor of neurology at Harvard Medical School and chair of the American Academy of Neurology Science Committee. It is the AAN Science Committee that oversees the selection of science being presented this week. Today, Dr. Rost will be presenting her choices for top science at the AAN Annual Meeting. Joining her are three authors of abstracts selected by Dr. Rost to be featured at today's press conference: Dr. Sean J. Pittock, Dr. Aaron Beck, and Dr. Alex Collison. Welcome, Dr. Rost, Dr. Pittock, Dr. Beck, and Dr. Collison. I would now like to introduce Dr. Rost to make some opening remarks in regard to her selections for this year's meeting. Dr. Rost?
Hello, everybody, and welcome. Welcome to Philadelphia. Welcome to the 71st annual meeting of the American Academy of Neurology. As we were highlighting this morning in the plenary session, there is a fantastic week of science ahead of you, and I hope you take full advantage of attending our scientific sessions, both plenaries, neuroscience and a clinic, invited science, as well as the original presentations by neurologists and neuroscientists who are flocking to our meeting from around the world. In this Top Science press conference, as we do every year, we select three top abstracts that represent the spectrum of excitement in science that is happening here and now. It is my responsibility to select those abstracts, but I also do that in council with my science committee members as we try to outline the theme and also the future of where neuroscience is going. So this year, the theme continues to be breakthroughs and innovations in neuroscience that lead to practical clinical applications. You will hear from three authors, and I just would like to underline the fact that we listen to your comments, that we expand the range of abstracts that are presented at this press conference, and we also bring to you the authors of the science so you can get into the details of of their work. And this year you will hear with regard to three very exciting developments which all address the spectrum of rare and previously thought to be untreatable disorders. You will hear some disorders that you perhaps never heard about, like Angelman syndrome. You will hear about some breakthroughs in immunotherapies that address a wide range of disorders, both on the neuroinflammatory spectrum, such as neuromyelitis optica, as well as one of the deadliest diseases we know in neurology, known as progressive multifocal leukoencephalopathy, or PML. So I'm very excited to present to you these three abstracts. I hope you take full advantage of our authors being present here, and we hope that the conversation will continue throughout the week as you continue to attend the meetings, as well as interact with our authors. So welcome.
Thank you, Dr. Rost. After the presentation today, we will take questions first by those of you here in attendance in Philadelphia, and then from journalists on the phone. Please remember, if you're on the phone as well as here in the audience, to identify yourself and your media outlet when asking questions. We will begin with the abstract authored by Dr. Sean J. Pittock, titled Efficacy and Safety of Eculizumab in Aquaporin 4 Antibody-Positive Neuromyelitis Optica Spectrum Disorder, a Phase 3 randomized, double-blind, placebo-controlled, multi-center trial titled PREVENT. Dr. Pittock?
Well, first of all, thanks very much, Dr. Rost, for the opportunity to present the results of our abstract. So first of all, neuromyelitis optica is an inflammatory brain disease that for many years was mistaken or often misdiagnosed as multiple sclerosis. It affects about 1 in 30,000 patients throughout the world. About 500,000 people have this disease. And it's characterized by aggressive attacks of optic neuritis, so patients can become blind, or inflammation of the spinal cord, we call transverse myelitis, and patients can become paraparetic. Untreated, this disease is devastating for patients. It can result in blindness or paraplegia in about half of patients within about 5 to 10 years. So this is a devastating illness. The disease is different to multiple sclerosis because in this disease, disability occurs because of the clinical attacks, not because of progression that occurs in between attacks. And so if we can stop attacks, then we can stop disability in this disease. And this is why this study is so important, because this study shows that a drug can potentially stop attacks in this disease. Neuromyelitis optica really hit the press with the discovery of the first ever biomarker for an MS-like illness in 2004 at Mayo Clinic, a water channel antibody, so an antibody that binds to a water channel on brain cells. And what we've learned through a global effort of investigators really passionate about this disease is that when the antibody binds to the water channel, it activates a protein or a substance called complement. And when that complement is activated, it is the complement that actually creates holes in the brain cells, and those brain cells then die. And also, complement also is an inflammatory agent that causes massive inflammation. So many years ago, we thought, when we were discovering the mechanism of the disease, and I think this is important because it's really the concept of, from dark room to discovery. But when we began to realize that complement activation was the key factor in the injury of the brain cells, we asked the question, if we block complement, can we stop the disease? And that led to an open label trial at Mayo Clinic with my colleague, Dr. Dean Wingerchuk, where we basically treated patients just open label. And we were amazed by the results, and that was published some years ago. And that really fueled the interest to do a randomized controlled trial. So this trial was a massive endeavor because, remember, it's a relatively rare disease. And I have to thank the patients because at the end of the day, these studies couldn't have happened without these patients going forward and being willing to take a placebo. So what we did was a study involving 70 centers in 18 different countries. It took many years to do. And at the end of the day, we found that if you take eculizumab at 48 weeks, 98% of the patients that got the drug were relapse-free. And 63% of the patients that got placebo were relapse-free. And the other thing we noticed is that even over the longer term, if you go out to 144 weeks, then 96% of the eculizumab treated patients were still relapse-free, and 45% of the placebo group were relapse-free. So this was a dramatic result, I think really showing a significant amount of hope for people with this disease. The concept that you can discover a target, understand the immunopathology of a disease, identify a novel mechanism, then identify a precision drug that targets that mechanism and essentially turn off or switch off the disease is very, very exciting. So thank you for your interest.
Dr. Rost, would you like to ask some questions?
Yes, please. I would like to comment. This is perhaps one of the reasons why I selected your work for presentation at this conference, is because it's a glorious example of what we can do with precision medicine once you identify the target and then bring it to fruition. So thank you for the work you've done. I did want to ask you a question, putting in the context of this breakthrough meeting where we have 3 phase 3 trials for NMO, which is obviously a pinnacle of achievement. Would you put it in the context of the spectrum of disease and the potential applicability, and whether there is any different mechanisms of action that are being targeted by one or the other ones? Because I'm sure you are familiar with the work of your colleagues.
That's a great question. So again, this is a wonderful time for patients that have a rare disease, because we've gone from no randomized controlled trial to 3, all of which have been completed around the same time, and all of which are positive. The range of mechanisms that have been targeted again comes down to the work of the researchers and the investigators in understanding mechanism. So for example, one of the drugs works on IL-6. IL-6 we know drives plasmablasts that make antibodies. And so the concept that you can hit the driver of the plasmablasts and those B cells that make antibody, and then if you block that, you can potentially have a benefit in the disease, is one way. The other way is a drug called inebilizumab, where that is an antibody targeting CD19. It's different to rituximab because rituximab targets CD20. So unfortunately, CD20 isn't expressed in many of the cells that make antibody, plasmablasts and plasma cells don't have CD20. So inebilizumab targets CD19, and so targeting that, we see a good result with a significant reduction in the likelihood of relapses. And then going back to the eculizumab, a different mechanism, again, a precision medication that potentially works in a totally different mechanism, but also has a positive result. Now, how this will all play out for patients is difficult to know. All we can tell you is we have 3 drugs, whereas last year we had none. This is a very good time for patients. Hopefully they will have choice, and hopefully as we continue to work in this area, we can try to identify which patients will suit which drug. And there's lots of work going on with many of my collaborators and a whole multitude of investigators throughout the world trying to better understand mechanism, trying to better understand which patients are going to respond to which drug. So it's a very bright day for patients with what is considered a rare form of inflammatory brain disease. But remember, it's just the start, because neuromyelitis optica is one autoimmune neurological disease, but there are many. There are 3 or 4 being discovered every year. And also, I'm hoping that we'll be able to purpose many of these medications for patients with autoimmune neurological diseases that extend beyond NMOSD.
Fantastic.
Okay. Dr. Rost, Dr. Pittock, thank you. We will now take questions from journalists in attendance. Please raise your hand and state which publication you're with.
Peterson with Trends in Medicine. So, in your practice, how many patients do you actually have with NMO?
So, that's a very good question. So, in our Mayo Clinic neuromyelitis optica database, we have about 500 patients. In my own personal practice, I probably see about 20 to 30 patients. At the moment, I currently have 3 patients that are actually on eculizumab, and they have received that through either the company providing the drug, or their home state has allowed them to get that medication because they had very severe disease. But so about 20 to 30 patients I see personally.
So as you start out with 3 drugs, which appear to be coming at about the same time, how will you choose, until we learn, how are you going to choose which ones get which drug?
So I think that's a very good question, and it's going to be difficult for me to answer that question because none of the drugs have become our FDA approved, and we're literally just at the start of recognizing the results of the drug trials. I think it's going to be interesting how we pursue trying to figure out which drug for which patient. I think it'll often comes down to the issue of what drugs will be available, what drugs will be covered. I think we'll also have to think about patients that are currently stable on their current medications. How will we take them off a drug that they're relatively stable on to put them on one of these new drugs? So I don't really have an answer to that question, but I do think as the environment changes and as we recognize which drugs are going to be available under what circumstances, then we can try and make those clinical decisions clearer. And maybe as a group, as a group of investigators working together, we can come up with guidelines that will help physicians make the right choices.
Will you take patients off?
Generally, my tendency is if patients are doing well on a drug, I would generally tend not to. But unfortunately, remember that most patients are not doing well on drug. So, for example, we know that even with rituximab, probably 40% of patients will relapse. With the other drugs, the relapse rate is probably higher. So at the end of the day, most patients will probably end up on one of these newer drugs at some point.
Hi, excuse me, Dan Keller, Roularta Publications. The one death, was that, do you consider it treatment related, the infectious pleural effusion?
So that's a good question. So first of all, that death by the investigator was not considered definitively related to eculizumab. The bug that was involved there was not an encapsulated bacteria. So it was not one of the bacteria types that patients getting eculizumab are predisposed to getting. The big one, as you know, is meningococcal meningitis, and there was no case of that in this study. So I don't think it was directly related to eculizumab. What I would say, though, is remember remember that if you look at the disability in the patients that went into these studies, they have an EDSS, an average EDSS of about 4 to 5. So these are patients with some disability. And remember, there's a spectrum. So there are patients that have much more severe disability. The other problem with neuromyelitis optica spectrum disorders is that these patients are teeming with other autoimmune disorders. So, for example, there's a very high prevalence of lupus, Sjogren's, and a whole variety of other autoimmune conditions. And many of the patients have many comorbidities. So you're going to see some additional disability relating to other diseases also. The reality is that all drugs are associated with side effects, but if you look overall at the side effect profile, in this study, the side effects that were identified in the eculizumab-treated patients were no different to any of the other diseases for which eculizumab is used. So the profile was pretty much the same.
Okay.
Like with other uses of eculizumab, like in PNH or something, do they get meningococcal vaccination before they go on this? And finally, does ocrelizumab fit into this picture also?
So that's a great question. So first of all patients that entered the study and any patient that potentially would go on eculizumab must have meningococcal vaccination, because that is one of the biggest concerns. And then obviously should be watched very carefully, and any type of or sign of inflammation should be treated aggressively. Now ocrelizumab, so it's difficult to comment on ocrelizumab because again, we're in a situation now where we're commenting on a drug that hasn't been tested in a randomized controlled fashion, and then trying to compare that drug to 3 new drugs that all have been tested in a randomized controlled fashion. Ocrelizumab certainly makes sense to use it. How ocrelizumab potentially would fall when compared to something like inebilizumab, where you've got one drug that targets CD20 and the other drug targets CD19. My sense is that at least in this disease, physicians will tend to use, if they're going to use one of these monoclonal antibodies targeting B cells, they're probably going to go for the drug that's been shown in a randomized controlled trial to be of benefit versus ocrelizumab. Rituximab already has a place in the space, but again, it has not been proven in a randomized controlled trial to be of benefit. And in a lot of the retrospective studies where we've looked at patients over a long period of time on rituximab indicates that a significant proportion of patients will relapse on rituximab.
I believe we had one more question from the audience, perhaps, or maybe not. Maybe the question was answered. I believe it was, okay.
So, Jörg Lewitz, Neurotypische, Germany. The pathomechanism is fairly clear in aquaporine positive, antibody positive patients. What's about the antibody negative patients, and how is the role of EL6 in these patients?
So that's a very good question. So I would argue that patients that are aquaporin 4 antibody negative, that have a phenotype that looks like NMO, I would argue that they have a different disease mechanistically. For example, there are patients that have MOG antibodies that can look very like NMO, okay, but they have antibodies that are targeting an astrocyte, versus patients with NMO who have an antibody targeting they have antibodies targeting oligodendrocytes versus the other disease where you have antibodies targeting the astrocyte. So I think mechanistically these are probably different diseases, and I think we just don't know yet. We very much understand and continue to learn about the mechanism involved with water channel autoimmunity. But in terms of those double negative patients, the patients that are negative for MOG antibodies and water channel antibodies, or those even just with MOG antibodies, I think we're just really beginning to learn about these diseases. And mechanistically, we have very little knowledge at the moment of what is the mechanism of damage in the autoimmune MOGopathies, or what we call MOGAD. So it's also evident from some work that's been done that if you take patients that have MOG antibody-associated NMO-SD, that those patients tend not to respond as well to immunosuppression medication. And so we still haven't even figured out what drugs should we be using, or should we even be using immunosuppressant drugs in all patients with MOG antibodies. So that's a whole other discussion.
Okay. We do have one more question from a journalist in attendance, and we will go to the phones after that. Let's go ahead.
Ann Sidor from Practical Neurology. You spoke about the different mechanisms of the 3 drugs that are in phase 3 right now, CD19, CD20, and CD5. Do those all have the same impact? When you target those 3 different molecules, does it have the same effect on the B cell? And do you see side effects of neutropenia?
Okay, so thank you very much. So just to clarify, so the CD19 and the CD20 antibodies, they have similar effects. They will get rid of your lymphocytes. So if you measure lymphocytes, like you do a CD20 count on a patient a month or 2 after they've received it, they'll have none. You won't detect any. So they have dramatic they get rid of it. But surprisingly, from a side effect profile, they do very well. The IL-6 antibody actually targets kind of a little bit downstream, so it prevents or it takes away the activation for the plasma cells to mature and push out antibody. Okay, and the eculizumab, where that's actually acting, that's actually not acting on the B cell at all. That's actually acting, that's blocking the complement, the C5, being proteolyzed through enzymatic action to C5a and C5b. So it blocks that point. So it's not having any effect on the B cell. So actually, interestingly, in this disease, the antibodies that are pathogenic remain high. But yet the patients don't have attacks because the antibodies are there, but they can't injure the cell because you're blocking the ability of that antibody to activate complement.
All right. Thank you. Thank you, Dr. Pittock. We will now take questions from journalists on the phone. If you
Conference has been unmuted.
Is there a journalist on the phone who would like to ask a question? If so, please state your name and publication. Okay, hearing no questions.
The conference has been muted.
Okay, we will now discuss the next abstract authored by Dr. Aaron Beck, titled A Pilot Study of Adoptive Cellular Immunotherapy for Progressive Multifocal Leukoencephalopathy with Ex Vivo Generated Polyomavirus Specific T Cells. Dr. Beck?
Thank you, and thank you for inviting me to share our work with you today. So the focus of our work is progressive multifocal leukoencephalopathy, or we call it PML for short. It's an opportunistic brain infection that's caused by a virus called JC virus in people who are severely immunosuppressed. Historically, it affected people with hematologic malignancies, so leukemias and lymphomas, and genetic immunodeficiencies, and was almost always fatal. And then in the 80s and 90s, there was a surge of cases associated with the AIDS epidemic. And now more recently, there's been new cases associated with new immunosuppressive medications used for cancer and autoimmune disease. And there's really no treatment for PML at this point. The only effective management is to rapidly restore immune competence. And if we can't do that due to the underlying disorder or because the drug that was used is slow to reverse, then PML is usually fatal and usually within months. So our study focused on those patients for whom immune restoration is impossible or too slow, and who really have an otherwise dismal prognosis. And this included people with genetic immunodeficiencies, hematologic malignancies, and autoimmune diseases on drugs that were hard to reverse or slow to stop working. And so our strategy, which was developed with colleagues in transplant medicine at the National Heart, Lung, and Blood Institute, was to borrow basically immune cells from first-degree relatives of our patients. So basically, we take the immune cells from the patients through a blood draw and culture them in the presence of viral proteins so that they become active against those proteins. And then we give them to the patients. And we call these cells polyomavirus specific T cells, or PYVST. We treated 12 patients with this therapy. All of them had to have worsening disease at the time of treatment, and they received up to 3 infusions. Each infusion was at least 28 days apart, and then we followed them for a year. And the primary goal was really safety, to make sure that this treatment was safe. And in particular, we were concerned that these cells, immune cells, getting into the brain to fight this infection might cause a pretty aggressive inflammatory reaction. We can see this in other diseases in which immunity is restored. For instance, in people with PML and HIV, they can have a very severe inflammatory reaction once they're started on antiretroviral therapy called IRIS, which can be dangerous and even fatal itself. Fortunately, though we didn't see any evidence of this with our therapy. In fact, it was very well tolerated with very few treatment-related adverse reactions. So of the 12 patients that we treated, 5 of them died of PML, all within a few months. However, the remaining 7 survived, and most of the 7 who survived had significant neurological improvement. And this was very encouraging to us because these patients, as I said, were worsening at the time of their treatment, and we did not expect them to do well. And furthermore, the results suggest that the treatment is safe. And then in addition, in doing this study, we've been able to look at some of the qualities of the cells and of the donors of the cells that give us some insight into what are important factors for maximizing the antiviral activity of the cell product, and that we think we can use to further optimize this kind of therapy in the future. And we think this strategy has real potential to be one of the first effective treatments for PML.
Dr. Rost.
Thank you, Dr. Beck. This is a phenomenal breakthrough. I would say as a neurologist myself, giving a diagnosis of PML to a patient is basically giving them a death sentence, and is one of the most dreaded scenarios in our clinical practice. So I thank you for all the work you've done on that. And I think it's also extremely timely because, as you were mentioning, that the surge of the cases that we recently have experienced is really tied to the successes of immunotherapies that we've developed over the years. So, there's obviously the pendulum of science that swings both directions. So I think that this is extremely timely. And I wonder, as I heard you presenting your work, I wonder that if you discussed potential strategies with regard to patients who are anticipated to undergo immunotherapies, whether there could be some banking of their own immune cells in advance of that, before we start treating them with, difficult to reverse immunotherapies. Not only their immune cells, but maybe potentially pluripotent stem cells that you can convert into whatever line of, hematological cells. So if you could discuss about options and avenues to test.
Yeah, so it's an interesting idea. I mean, I think certainly that could be considered. We thought about doing, even in this trial, with autologous cells, but given that the patients have this infection, it means their immune system's not working, and although we might be able to get some antiviral activity from the cells themselves, they probably wouldn't be the ideal cells. Certainly you could consider doing that and taking the cells before the patients start on the treatment. I think, the issue is that PML is still a very rare complication of treatment with most of these drugs, and so it would be a big resource to involved in saving those cells, but it's certainly a possibility, especially as the technology to do it gets better. And this therapy has been really pioneered in the bone marrow transplant field, where it's being used more and more for patients who have had bone marrow transplants and who are susceptible to a number of different viral infections. And in them, they're actually given sometimes prophylactically, the cells, and they generate cells against multiple different viruses and give them to the patients prophylactically. And in those cases, the cells are usually from the bone marrow donor themselves.
Okay. Thank you, Dr. Rost and Dr. Beck. We will now take questions from journalists in the audience.
Hi, it's Espen with Neurology today. Dr. Beck, of the 5 patients who died, I assume all 12 of these patients were in pretty bad shape. The 5 patients, is there anything special about the 5 patients who died that give you some hints as to who would benefit most from this treatment?
Yeah, that's a great question. So we're still analyzing the data, I think, for this, so I don't have a complete answer for you, but I think, one thing we looked at, of course, in terms of age, sex, baseline lymphocyte count numbers, time since their initial diagnosis, and there was no difference in any of those. There's also no difference that we saw really in lesion location or lesion size on the MRI, at least in qualitative analysis. Where we have seen a difference is that those 5 patients had much higher JC virus copy numbers in their spinal fluid, so we can measure the amount of virus that's in the spinal fluid, which is a proxy, although not a perfect one, for what's going on in the brain. So those patients had a much higher number, and interestingly, if we look at the patients that we screened for enrollment in our protocol but who died before they could even be enrolled and infused, those patients Some of them had a number in that high range, but a lot of them actually had numbers in the lower range. So that high range doesn't necessarily, so that high range I think is a very bad prognostic sign, but a number in the lower range doesn't mean a good prognosis, but it means potentially that you could respond to a treatment such as this one.
Any indication that the treatment itself had an impact on outcome as far as bad outcomes?
No, I don't think so. I mean, I think the patients that passed away kind of continued to follow the course that they were following at the time of their infusion, and we didn't have any indication that it was related to the infusion.
Other questions?
Thomas Müller, Springer, Germany, Springer Nature, Germany. Death rate from 5 of 12 seems pretty high still. How do you prove efficacy? I think it's not possible to make any randomized controlled trials. And
Yes.
and were these patients in a special, very severe state, or would they have all of them died, or?
So it's really hard to predict with PML who's going to live and who's going to die, and I think that that's a problem that we have, and that it's one thing that needs to be addressed to really do good trials of treatments for this disease. You know, we did pick patients who were getting worse and who we had no treatment for, so we assumed that most of them would die without treatment. Of course, we can't tell, and really, you know, this trial was designed to determine safety, and so efficacy was really a secondary outcome. And of course, we can't say how many of those patients would have survived without this treatment. We have, I think, in the work that we've done with the patients in the trial, as well as patients that we brought to the NIH and screened for the trial, but who didn't end up enrolling for various reasons, have a better idea of, at least in this population of patients that come to the NIH for seeking treatment, have an idea of the survival rate. And so we've been able to, with this data, kind of have a better ability to estimate what a sample size you would need to demonstrate efficacy. And we estimated it would be about 25 patients to see a 30% increase in survival. But it is hard because depending on the underlying disorder, which is quite diverse, and the level of immunosuppression, outcome really varies. So it's a difficult question. And yes, it would be hard to design a randomized trial for a disease that's fatal like this one.
Hello, my name is Helen Brooks from the Lancet Neurology. I wondered if you could expand on the improvements in neurological outcomes that you mentioned.
Yeah, so you know, of course, as in most neurologic disorders, the range of disabilities is quite broad depending on where the PML lesion is in the brain. And so we had patients with all sorts of disabilities. I treated one patient in particular who, really the nadir of her disease, she was really not speaking at all, was unclear that she understood much of anything, was bedbound, and by the time of her last follow-up, she was walking with a walker, she could carry on conversations. She still had significant disability, as a lot of our patients did, and I think that just highlights the need to treat patients really quickly. In fact, a lot of the patients who came to us maybe had survived a few months before they got to us, and because their doctors had told them, you're going to die from this, and when a month or two passed and they didn't die, then they started to look to see what they could do. But it's a really difficult disease to predict, and clearly treating it as quickly as possible once it's diagnosed will be important, because although we did see improvement, we clearly, I don't think that we could hope to reverse all of the damage that's done.
Okay. One more question from the audience. And the authors will be available after the press conference as well if you have additional questions.
Dan Keller, Roularta. Did you look for any level of graft versus host disease, and is a little bit of it beneficial? And I assume you're looking to suppress the virus, not clear it. What was the persistence of T cells, and would this be a lifelong treatment?
Yeah, so I think that So the first question was about graft versus host disease, and we didn't look specifically. We have started to tried to see what the fate of these cells were, how long they persist, and whether they get into the brain, because really this type of therapy has been used mostly for systemic infections. So there's very little that we know about how the cells actually get to the brain and how many of them. So we've just very in the early stages of doing that, and we do in the first patient that we've looked at HLA typing and CSF lymphocytes. We do see donor cells in the spinal fluid, but we don't know how long they last, and we don't expect these cells to last for very long. We expect them to divide for a while and then to die. So I think that I don't think what we see in PML is that generally people go into what I guess we would call remission, where the viral copy number in the spinal fluid goes down or becomes undetectable, and then patients are stable. What we don't know really is at what risk they are for recurrence of PML, and we're always very nervous in those patients about ever restarting any sort of immunosuppressive therapy, which is a big issue in these patients because their underlying disease persists even when the PML goes away. So potentially it would be something that would need to be reused at a later date, but not necessarily on a chronic, regular basis.
Okay. We will now take questions from journalists on the phone.
The conference has been unmuted.
Hello?
Hello. Please state your name and the publication you're with.
Hi, this is Roger Spell. I wanted to ask about, you mentioned that there were some factors for maximizing the potential of the cells. Do you have any more comments?
Yeah, sure. So we did look at a few characteristics of the cells themselves. We looked at the composition of the cell product. So these are lymphocytes, but to look at what kind of lymphocytes they were. We didn't see any difference in T cell number, total T cell number, or CD4 or CD8 number. Again, of course, this isn't a very small sample size. We did see a little bit of a difference in the percentage of CD56 positive cells. So the cells given to patients who we think responded to the therapy, or the patients who survived at least, had a lower percentage of CD56 positive cells. These are predominantly natural killer cells. And so we don't really know what the meaning of this is, but perhaps these cells have a regulatory effect or are somehow detrimental to the response. We also looked at antiviral activity of the cells, and we did see that it was much higher. So this is cells, again, put into culture and exposed to the viral peptides, and to see how much cytokines they produced. And the viral activity, the percent of cells that responded, was much higher in the cells given to the responders than those given to the non-responders. And so I think this, first of all, highlights that these cells really were active against the virus, and is more evidence that the therapy actually worked. In addition, it's something that certainly could be screened for, and we have a marker at least of how to optimize things going forwards.
The conference has been unmuted.
We had a bit of an echo, so I muted you. Do you have any follow-up questions?
No, thank you. Interesting.
Okay. Thank you. Anybody else on the line with a question? Okay. Hearing no further questions. Mute that.
The conference has been muted.
Okay. We will now discuss the final abstract, authored by Dr. Alex Kolovzon, titled STARS, Results from a Safety and Efficacy Study of OV101 Gaboxidol in Adults and Adolescents with Angelman Syndrome. Okay, go ahead.
My turn?
Yes, go ahead, Dr. Kolovzon.
Well, so first, thank you. It's extremely exciting to be part of this really amazing work, and I'm really pleased to share the results of our small study. So Angelman syndrome is a rare, genetically defined syndrome. It's characterized by profound intellectual disability, seizures, gait problems, motor problems, anxiety. These kids are really very, very disabled. It's diagnosed for the most part, or at least it starts to occur at birth. So it's really a very profound kind of developmental condition. It was been described for about 50 years, and yet there's absolutely no treatments. The only treatments that exist are really very symptomatically driven. So here we're taking a genetics-first approach. Having identified the gene, there's some understanding of what the underlying biology is, and it seems to relate to deficits in tonic inhibition. So it's a GABAergic-driven disease state. GABA is sort of the primary inhibitory transmitter of the brain. It sits in balance with the primary excitatory neurotransmitter, which is glutamate. So what we think that this compound is doing is actually reversing the deficits of tonic inhibition and sort of restoring that state to these kids. This is the first industry-sponsored trial in this space. So what Ovid did is a phase 2 study across about 12 sites, and it was designed just to look at safety and tolerability. And so what we found was that this was actually a safe and well-tolerated drug. There were no significant differences across groups in terms of the tolerability of the medicine. We also did a whole bunch of exploratory endpoints around clinical outcomes. And so we were really very excited to find that globally these kids seemed to improve on a clinical global impression scale. And the improvements seemed to be mainly driven by a few different domains, including sleep, motor behaviors, and behavior in general, and even perhaps communication behaviors. So we think that the phase 2 results are going to give us a lot of information about how to best design our next study, which is going to be a phase 3 that we're already starting to prepare for. We think that this is going to be an opportunity to actually define a much better outcome measure in Angelman syndrome, because at the moment, the outcome measures that we have for developmental disorders in general, like Angelman's, but for even in Angelman's, is we really don't have anything that's going to capture the heterogeneity of the disorder. We don't have anything that's really specific for Angelman's in particular. And so this has been an opportunity for us to step back and say, what do we think is really important to look at in the context of clinical trials, especially sort of genetics first trials where we think we're actually targeting the underlying biology. And so we're anchoring our global impression in specific domains that we've seen now improve in the context of the phase 2 trial.
Okay, Dr. Rost.
Thank you so much for your presentation, and thank you for bringing this work to the AAN. Some of the reasons, in addition to the design of where you go from genes to developing a treatment theme that you probably already gathered from this conference, I also was taken aback by the importance of the work that you do by highlighting the spectrum of developmental disorders. And some of the highlights of science that we're presenting this year is addressing the disorders that begin in childhood and then kind of span the lifetime of individuals who nowadays survive and function within the society with the burden of neurological and developmental disorders. So that was very important for us as well. My question to you is whether you think that the current setup of clinical infrastructure that we have in care of those patients who are diagnosed in their very early childhood and then cared throughout their lifetime or lifespan, whether we're set up for effective trial designs, identifying and also caring for those patients, and as you were saying, that you're just angling at particular outcomes in this arena, and what some other challenges that you are anticipating setting up the trial successfully?
Yeah, so those are all really good questions. There are probably 10 or 20,000 patients that have been identified in the U.S., and really probably every day new patients will be identified with the advances in genetic technology. Patients that weren't previously identified are now being identified. And there have been many different clinics that were set up, not just at these 12 sites, but so I think we have a fair number of experts, centers of excellence. We've already established a clinical trial infrastructure. So I think in that sense, we're kind of ready to go. The challenges we face in terms of measuring outcomes, especially over short term in kids that are so disabled, is a different one. And I don't think we're going to have one singular outcome. I think the idea is to have a global measure that really captures heterogeneity across each child and sort of allows for kids to be compared to their baseline, and each has their own control in essence, but with specific domains in mind, because every kid has sort of a different composite of symptoms, essentially. But that's the big challenge. And you mentioned something that I wanted to follow up on, which is the importance for neurodevelopmental disorders in general, because it's not just Angelman's that faces this, right? There's many, Fragile X syndrome and Phelan-McDermid syndrome, and there's many different disorders. And I think hopefully what's being done here is going to have relevance much more broadly, and hopefully some of the measures that we're developing and we'd like to get approved will have relevance.
Thank you, Dr. Rost and Dr. Kalovzan. We will now take questions from journalists in attendance.
Lynn Peterson with Trends in Medicine. So in terms of looking at endpoints for this, well, let me clarify first. Is the next trial a phase 2 or a phase 3?
Phase 3.
3.
Yeah, we're already preparing for phase 3.
Okay. Then there's a 50 or 60 patient phase 2 that started also?
So we completed, it's actually 88 patients enrolled, 78 patients completed phase 2, safety and efficacy trial, where we hit our primary efficacy endpoint, even though it was by nature of a phase 2 exploratory.
Which was CGI?
Correct.
Okay. And so within it, so is CGI really the only endpoint, functional endpoint that you can use, disease-related functional endpoint?
So because we had many other endpoints, signals and even significance on several of them inform our CGI. And so our next step is essentially to take that CGI, but anchor it in specific domains that we think drive the effect. And that's what we're going to bring forward to the phase 3. Motor, sleep, and some behavior things like anxiety, hyperexcitability. These are kids that are, this is what's called the happy puppet syndrome, if you've heard of it, right? So they're kind of all over the place. They're very excitable. There's a lot of kind of restless and agitated behavior.
All right, any other questions?
Do you think diagnosis and very early intervention will prevent developmental problems that you see, or could there be a more genetic basis not only related to the GABA-A receptor?
Sure. So I think that, yes, there are probably other developmental issues. We don't believe that this is going to be curative. I think this is going to be profound in terms of the symptomatic improvement. I do think that earlier intervening is going to have better outcomes, especially around cognition, right, which is sort of our holy grail, and that we're really not able to show in the course of a brief trial. But it's more complex than just that. So these kids will still be symptomatic. And as a related point, people often ask, if you don't intervene in early childhood, but you only intervene in adulthood, will you still have an impact? And I think the answer is still yes. And I think you can see preclinical models that will show reversal of phenotype depending on which point in the trajectory you intervene.
Any more questions?
Elizabeth Slavinka from MedPage Today. I had a question about the adverse events. Could you expand on those? Were they different between treatment arms?
Yeah. So we had 3 arms in this study. There was a once-a-day dosing, a twice-a-day dosing, and a placebo dosing. And that reminds me actually that one of the really important points that came out of the phase 2 was it helped us decide that the once-a-day dosing was significantly more effective. In fact, that's what separated from placebo, not the twice-a-day dosing. And it seemed as if some of the side effects were more common in the twice-a-day dosing, but when you looked across groups, tolerability was the same. So there were side effects in all the groups. The side effects, for the most part, were nuisance side effects. They were not serious side effects. We did have 2 SAEs around seizures, but these are all kids who have seizures at baseline. About 90% of them have seizures at baseline. So I think 4 patients overall withdrew from the study. 1 for irritability who was on placebo, 1 for irritability who was on medicine, 1 for sort of muscle changes, myoclonus, and 1 for seizures. So the tolerability profile was really relatively benign, I would say. So not that there weren't side effects, right? All kids have side effects, but it seemed like the side effects occurred just as frequently on placebo, and those that did occur were not especially concerning.
Do we know why that twice daily dosing was less effective, or why it might have been?
So we think that there may be some tolerance that develops to the twice-a-day dosing, that we're kind of overshooting perhaps, but we're not sure exactly.
I believe we had one more question from the audience.
Shri Ananda from MedWire News. So this is one gene, right? Are you looking at any other genetics-driven approaches for this condition?
For this condition? Well, so this condition it's caused by a specific gene, the UB3A.
But like, are there other aspects of it that you could tackle? I'm not being very clear.
Are there other aspects of the
So the
Angelman
drug
syndrome?
is sort of attacking GABA.
Correct.
Are there variations of that you could be looking at?
Oh, so I mean, there's a relatively deep pipeline where you could be looking at this particular compound in many other conditions where GABA is effective, if that's your question. Absolutely.
Right.
Yeah, I mean, there's a lot of developmental disorders where you have an imbalance between GABAergic and glutamatergic systems, where this medicine could potentially have relevance. Fragile X is another one, obviously. In terms of the different genetic variants within Angelman syndrome, no, we haven't gone that far. That would be parsing it a little bit too finely, I would say.
All right, we will now take questions from journalists on the phone. Does anyone on the phone have a question?
Yes, hi. Damien Garden, staff. I had a question for Dr. Rost with respect to this CGI endpoint. How familiar were you with that? What do you think of that as a metric, as a sort of global method for gauging whether these patients are getting better?
I'm going to let the expert, Dr. Collison, answer that question if you don't mind.
Hi, Damien.
Oh, sure.
The question is about the CGI. So, yeah, I think that there can be criticism about the CGI because it's not as well operationalized. It's not objective. There is subjectivity to it. It's a clinician tool. For us, I'm a child psychiatrist, not a neurologist. We value parent feedback heavily. We value feedback from lots of different sources. So the CGI allows you to kind of collate information from a lot of different sources. It also allows you to rely on your own observation in the room. So it's not a perfect measure. I think the goal is to make it more perfect in terms of really operationalizing which domains we're trying to tackle within the CGI. Certainly the CGI is kind of it's a tool that has some precedent within approved trials, but typically it's considered to be a co-primary measure with another one. The problem in Angelman syndrome is that this is it's just so rare and so heterogeneous that we don't have an established validated tool. So we're going with where the science is in terms of what the data showed in the phase 2, and kind of just doing our very best to create the best tool we can.
Any other questions on the phone?
The conference has been muted.
Okay. Thank you, everyone, for coming here today. On behalf of the American Academy of Neurology, I would like to thank Dr. Rost, Dr. Pittock, Dr. Beck, and Dr. Collison for joining us here today in their presentations. And they will be standing by for some questions afterwards if you do want to ask some additional questions. And thank you to all of you here in attendance and on the phone. For more information, you can go to AAN.com, the American Academy of Neurology. That's AAN.com for the American Academy of Neurology. I'm Renee Tessman, and thank you all for being here today.